Right, hello everybody. Welcome to Target Ovarian Cancer's Breaking Down the Barriers to Early Diagnosis. I'm here with Angela Dunn. She is manager of the Target Ovarian Cancer Pennine Lancashire pilot for IT alerts. We also have Catherine Gilmore. She is a patient and she's the public voice of NHSE Cancer Programme in South Yorkshire and Derbyshire Cancer Alliance. And we also have Catherine Pearson, who is the clinical change manager here from Target. It's our first early diagnosis event to try and diagnose every woman at the earliest opportunity. Following the presentations, you'll have ample opportunity to ask questions. Please put them in the chat. We'll try and answer as many as possible in the time. Any that we don't have chance to answer, you can join our GP network following this webinar. You'll be able to get an FAQ of any questions that you hadn't got answered. You can watch it again on a YouTube link if you want to. Just what we're going to do is we're going to run through a few slides to show why we're passionate about the use of IT, and hopefully you will prompt you to use them, sign up to us, and we need feedback. We always need feedback on how useful things are, because that's how we get our funding and how we manage to help you to help us. So it's really important. So Andrew is going to show you how pop-ups work. Catherine is going to give you unique patient perspective, and hopefully by the end of this you'll have some food for thought. So just a few housekeeping. Please go on mute, use your chat function, and you can use put your hand up if you wanted to ask a question, for example, and don't forget at the end we will send you any questions that we haven't been able to answer if you join up to our GP network. Okay, so let's get started. Why we did this? Unfortunately, this is effectively a postcode lottery, because as you can see, if you can diagnose women at the early stage, you get a far better outcome. And this varies hugely. I mean, 22% to 63% is a huge variation, really, and we're trying to get rid of that variation because variation is bad. Unfortunately, there's a large proportion of women who die within a couple of months after diagnosis, and if you're from a deprived area, unfortunately, you're much more likely to be in that group. So it's a very important thing that we can do to try and get this. Public awareness, unfortunately, is not great. Smear test is widely thought to cover ovarian cancer, and we need to get past this urban myth. And it's really important to train up your nurses as well, because they have the ideal opportunity to educate women when they do a smear test. And unfortunately, GP awareness is poor. We've still got that old chestnut of a silent killer, and it isn't. It's subtle, but the symptoms are there. Symptoms are definitely there in the first stages, not only in the late stages. And we're seeing women come into us 3 or more times, to try and get a diagnosis before they're actually referred on for further tests. Also, NICE guidance came out in 2011, and still we have a large percentage of GPs, 15% are still not aware of those guidances, and they're now 12 years old for who to refer, etc. So it's really important that GPs get on board with this. We hate misdiagnosing things, don't we? We hate those sort of diagnoses when we haven't managed to achieve something. So hopefully today will give you an outcome. So I'm going to hand over to our unique patient's perspective, and this is Catherine Gilmore for you to take us from here.
Hello there. Hi. So I am speaking to you from lovely Peak District today in sunny Derbyshire. What a lovely day it is here. So my name is Catherine Gilmore. I was diagnosed with ovarian cancer at stage 3B. And what that means is basically at the point of diagnosis, my cancer had already spread throughout my abdomen and throughout my pelvis. So my surgeon could see it on my rectum, she could see it on my liver, she could see it across my diaphragm. So it was already very widely spread at the point that I was diagnosed. And as Vicky just said there, early diagnosis is so important because the difference in the stage can be the difference between life and death. We know this. We know that the statistics kind of tell us that. And it's the difference in quality of life as well, because the earlier the stage that you get diagnosed, the less intervention you actually need, and the less likely you are to need something like a stoma or you know, treatments that are going to give you quite life-changing things that you have to learn to live with. I was actually, I'm considered to be in a very lucky minority. So it's actually been more than 5 years since my diagnosis, and I am grateful every single day for that, because I know that that could have been so very, very different. But it's not that simple. I have gone past my 5 years, but you know, last Christmas Eve, whilst all my friends were sat in the pub having drinks, celebrating Christmas, waiting for it to arrive, I was actually sat in radiology, also having a drink, a lovely CT contrast drink that we all love, and with a cannula in my arm, waiting for my next scan. And a couple of weeks later, I found that actually the cancer was growing again. So I am still on the cancer journey. It's not over just because I got to those 5 years. And one of the hardest things that I think about really when kind of sitting there in that waiting room is, could this have actually been any different? So if I take you back to when I was diagnosed, I was actually ill for around 4 years before I was diagnosed. And in the last 12 months before I was diagnosed, I was actually very ill. And if you took a textbook with ovarian cancer symptoms in it, and if you listed mine, you actually pretty much ticked everything on it. So when I hear that ovarian cancer is silent, it does kind of sometimes take me aback a little bit. Is it? Yeah. Don't think so. Not for everyone anyway. So going backwards and forwards, we kind of became a bit of a thing with my GP. We did try a few things. I went to counselling a couple of times for some of the symptoms, which obviously didn't work because there were tumours pressing on my bladder, there's tumours pressing on my bowels. I had cervical smear test for STIs, obviously didn't show anything because it doesn't, and it was actually quite painful, more so than usual, and quite difficult to do as well. Various blood tests for inflammation, edema, looking for changes in my bowels. And one of the things actually that happened was I was referred onto the bowel cancer pathway at one point. And I thought, wow, great, we're taking this seriously. This is good. We're going to look at it. The problem with the bowel cancer pathway is it doesn't actually pick up anything that would point you to ovarian cancer. So you go through the pathway, but you don't have a CA125 test for it because that's not for bowel cancer. You don't actually have a scan while you're looking for bowel cancer. You do other things, but you don't do anything that would actually pick up ovarian cancer itself. And so because of that, at the end of it, the hospital sent me back with this diagnosis of IBS. And so that should have been an answer. It should have made me happy. It should have made my GP happy. It should have kind of got me to the next stage of doing something about it. Unfortunately, in my case, what it did was it actually created an additional barrier, because what happened then was I had this diagnosis of IBS, and that was it. It explained things. And so it took another 5 months before anyone did a CA125 test, which actually did look for ovarian cancer. And in that time, you know, things will have grown. And that CA125 test did pick up that there was a problem. I went on to have an ultrasound, and that picked up that I had these tumours. And so I went on to go on to be diagnosed with ovarian cancer. I only needed these 2 tests in all that time, 2 tests that picked it up for me and took me on to help save my life, which it did. So I'm going to pass on now to Angela, who's going to talk you through what Target have actually been working on.
Thank you, Catherine. Powerful stuff there. Great to hear your story. And thanks everyone for attending. Hopefully you'll get something out of this. So my name's Angela Dunn. I've worked on the cancer agenda across the Pennine Lancs CCGs for about 10 years. And during that time, we developed really good working relationships with all the GP practices with the clinical support team and also the Macmillan GP who we work very closely with. So when we saw this opportunity to actually try something new, we've done lots of one-off projects and we're quite innovative and we try different things. But when this opportunity came up to work with ovarian cancer, we investigated it and thought it was certainly worth having a look at, see if there's anything we can learn. So I had numerous discussions and good chats with Natalie, who's Catherine's predecessor, and we landed on doing 3 projects. So we thought we'd try 3 different options. One of which was a 6 months, it was a one-off 6 months retrospective audit looking at patients who'd had a CA125, which had been normal, also a new diagnosis of IBS and diverticulitis, but no CA125 recorded. So they were the new diagnoses. So we contacted anybody in the last 6 months and offered them support if the conditions worsened or remained the same to just come back to practices. So we did that as a single project. The main one we did, which we're referencing today, was around the development of a pop-up, a clinical alert. So this is a pop-up that will exist in the EMIS system. And the parameters that activated the pop-up were a new diagnosis of IBS or diverticulitis for a woman aged 50 or over, where there was no CA125 recorded. So it's fairly rare to have those new onset conditions after the age of 50. So our suggestion was to actually undertake a CA125 point test at that point. So that was a pop-up that we developed. As I say, we've worked very closely with CSU, the clinical support team, and they were very invested in it. The lady I worked closely with, her best friend was actually suffering from ovarian cancer at the time. So she was really invested and wanted to make it help. And she understands my ramblings. If I say, can we do this? She's very good at making it work. So we use the pop-up, we've done them previously, but GPs report that they do get pop-up fatigue. And patients will go in and they'll open the clinical notes and you might get a plethora of pop-ups saying they need this jab or that jab or this test or that test. So luckily this doesn't happen in that way. It's only activated if it's a new entry into the patient's records. So it will actually come up and grab their attention more than some of the others where they're coming up 4 and 5 at a time. So the recommendation was that it would prompt them to actually do a CA125 test to aid their diagnosis. As part of the work and with the CSU, we coded things so that we could do some analysis afterwards, but rather than just numerical reviews, we also we did not a questionnaire, but we invited comment and feedback. And around this IT alert, you can read the feedback and the responses we got in the Target Ovarian Cancer report on these projects. But everybody, all the clinicians who came back, and we did this across 18 GP practices, so probably around 40 GPs, they all indicated that they found it a useful tool, that it did flag up to consider ovarian cancer. And it did identify 2 ladies who were new diagnosis. They did the CA125, and there were some 2 cases of ovarian cancer found. I don't think it actually did save their lives, but it certainly identified them a number of months sooner and was able to improve the care that they were given and give them better treatment and care. So just a couple of statements that came out that the IT alert was smart in every way, so it helped them to recommend. They recommended that it's shared, and it just brings ovarian cancer to the GP's mind. As has been referenced, it's not one of the most common ones, and it's not ones that immediately springs to mind. The thought that it's a more silent cancer, and that it's masked by, and the fact that it is masked by the IBS and the diverticulitis is often given as a reason for the condition. So many practices did retain this. They actually kept the pop-up, and we are sharing it more widely because it's not intrusive. It doesn't require lots and heaps of work for the practice once it's installed, and it's not something that's regularly flashing up, so it does grab their interest when it does actually pop up on screen. Thank you. As I said, we did 3 projects. We did the 6 months retrospective, we did the pop-up alert, and then a further project that we did was that every month There would be an EMIS search again, so we're using the CSU, and they ran a search identifying ladies with a normal CA125. So we then used Accurex to send them a message saying if the conditions remained the same, worsened or changed, to come back to practice, and offered them often a phone number, and physician associates would be able to answer any questions. So this took the workload out of the GPs a little bit and gave it to some of their other clinical staff. And it also raised awareness across the board. So it wasn't just GPs who were becoming more aware of signs and symptoms. It was the physician associates, and it was even down to the admin who were running the searches. So it was something that we feel strongly about sharing the awareness of the conditions and the symptoms across all levels of staff and all grades of staff. So there was some education into staff, into practices who were running this around that, and we did that in conjunction with Target Ovarian Cancer, and just raising awareness generally of signs and symptoms, and also, as you said, what the actual test is as well. I think the PSA is widely known, the CA125 not so much so. So it's really a continued thing about sharing information around this, and we are continuing to offer all practices this safety netting search as well, so they can still access the pop-up and the safety netting search, and we are going to push these out across all our practices locally. They're very cost effective, and they're not very labour intensive, which are two key things for practices to consider. So I'm just going to pass back now to Catherine.
Okay, thanks, Angela. Okay, so I'm going to take you back into my story a little bit here. So I've been diagnosed and I've had some surgery, and my oncologist has sent my diagnosis letter through to my GP, and my GP rings me, and it was quite a memorable phone call, and I will always remember her saying this to me. She said, "I am so sorry. We just didn't think you could have ovarian cancer. We just didn't think it would happen." And she just sounded so shocked. So I thought, gosh, right, okay. what do I do with this? Well, in the months that followed, I joined the ovarian cancer patient community, absolutely lovely community, full of really lovely people. And I found that my story was actually not unique. And it was happening all over the country, that people were having a lot of elements are very similar. A lot of people misdiagnosed with IBS at an age where you wouldn't necessarily expect that to happen. And cancers that are stage 3 and stage 4, so much more difficult to treat, much more difficult to survive for as long with. And I think it was the diagnosis part of my story that really was the inspiration for me to get into awareness raising for people and patients, prospective patients, but also going to talk to medical students as well and raising awareness of ovarian cancer there. But then also to get into being a patient representative. As Vicky mentioned, I am on the rather catchily titled PPV forum for the NHS England Cancer Programme, because I thought, you know, if I want to change anything, let's go and change it there. And a lot of the projects that I've worked on there, we are changing things in pathways, and it's all, you know, we look at this bit and we look at this bit and we look at this bit and we change it. And I realized quite often, one of the things I was saying was, this is great. But I mean, one of the problems I had was someone would have had to have thought to put me on the pathway in the first place. And that my GP actually told me that that was the problem. She rang me and told me that was one of the problems they had with me. So how are we going to change that bit? Because being a GP is very difficult. You have to know a lot of stuff. So have we got ways that we can help GPs identify this? So I think one of the things that really excited me about the work that Target were doing was they were actually looking at this. They were trying to address this particular issue. And it does kind of all sound like if everything comes together, some of these missed opportunities that I think we do have in some people's stories, that are things we can do. If we're all coming together, if we're all putting these projects together, we can actually change these things. And that's really exciting to me, because although I was diagnosed 5 years ago, I still see these stories coming through week after week after week, people coming in saying the same things that I did, that happened to me. And I have this kind of personal goal here as well. And my goal here is to stop doing this, quite simply. And by that I mean, because I don't need to, because my story becomes obsolete, because the people coming through, yes, they are diagnosed with ovarian cancer, but it's earlier. It is a much earlier point. Things are changing. They don't have the same rubbish survival statistics that we do at those later stages. They don't have the same interventions that actually have quite life-changing effects on them, because they are being diagnosed much earlier. And I think that it is actually possible to do that, because if I didn't think it was possible, I wouldn't actually be sat here today. I do think it's possible, and I think Target have done something quite exciting that will actually help to change this. So I think we're going to go to questions next. So I'm handing back to Vicky.
Right, if there's any questions on any of this, please put it in the chat box, and we'll coordinate this. Just really to sum up, I mean, Catherine has just given us a very powerful message as healthcare professionals, that realistically, you know, we need to know the symptoms of ovarian cancer in the first place, and try to think laterally as well, because I think as GPs and anybody in healthcare, we tend to sort of put things in boxes. You know, you see a gastroenterologist or you see a gynecologist, and we don't have that kind of lateral thinking sometimes that we need. So I think, first of all, being very much aware of the symptoms of ovarian cancer. So if you do see anybody with abdominal pain, bloating especially, because that's up there with the symptoms, urinary frequency, changing their urinary habit, and indigestion or feeling full up, those are all things that should be flagging up really. I mean, indigestion, it's ever so easy, isn't it, to kind of go down the route of doing an endoscopy, upper GI endoscopy, and giving them omeprazole and things like that. And it's very easy to go very straight down the line of bowel investigations, pretty much like Catherine had finally, that led to the diagnosis of IBS. And I think that we need to start thinking of ovarian cancer very much as abdominal cancer, which we're going to come on to at the end very much. You know, once we get it in our head that if somebody comes into us as a woman with abdominal symptoms, especially if they're over 50, because unfortunately older women are more likely to get it, then we really need to be thinking of ovarian cancer. But at the same time as we do our FIT, we ought to be doing a CA125. Just to answer the question, we've got one here. Are all types of ovarian cancer detected by a CA125? No, in a nutshell. Unfortunately, ovarian cancer is a wide term. It's an umbrella term for lots of different types of cancer. Now, if you're over 50, if you're postmenopausal, you're more likely to get a serous epithelial type. Now, that does cause a rise in CA125. The under 50s, the premenopausal, get a different histological type, and they can get a variety of types of ovarian cancer. And some of them obviously arise in the fallopian tubes, which is what we're finding more and more. So unfortunately, in younger women, 50% may have a normal CA125. And again, that's why it's important to think laterally and do a scan. In older women, they're more likely to have a raised CA125, but there are, unfortunately, as with the PSA, there are false negatives and false positives. So it's a tool, it's useful, but please don't rely on it completely, because you need to do a pelvic scan, and a transvaginal scan would be ideal. Next question, I work as a CNS. Is the IT system you had mentioned in the alerts and it rolls out to all GPs? Right, this is something that Target are currently working on, and at the moment you can do it through Ardens. If you've got Ardens bolted onto your system and you use EMIS, it's very easy. You just light that alert, and people who have a new diagnosis of IBS, it will pop up. There is no mention of a CA125 in the last 6 months. Have you considered ovarian cancer? It's not obtrusive, just like Angela said. It's very easy to activate. It's Ardens now, I think, are with 60–70% of GPs already. It's a little bit more tricky with System 1, but if you talk to Ardens, there is a link through the NG12 cancer alert, so that you can do that. Right, this one is for Angela. Do you know how many alerts produced the 2 ovarian cancers were diagnosed in the pilot? So over to Angela for this one.
No, we don't. That's not something we could actually measure because it'll just pop up and leave no record. But there is some information included in the report. And we just asked, it was more about GP, did you notice it when it popped up rather than how many times did it pop up? We wanted to know that it was flagging it up rather than the actual number that was produced, number of times it was produced.
Yeah, it's a difficult one to evaluate that, isn't it? But I think the most important feedback is that GPs who had that, you know, all of a sudden they made that link between abdominal symptoms and ovarian cancer. And it's a fantastic prompt, really, because you're probably like me. I do get a little bit of pop-up fatigue because we've got the pop-ups and everything else on our system. But I must admit, I find that one very, very useful. And when I saw it for the first time, it really made me stop and think. And certainly because of the problems with making sure that all GPs make that link between abdominal cancer and ovarian cancer, it's there for you, and I think it's absolutely brilliant. So although in the pilot study it was only 2 people, I'm sure it's going to help an awful lot more from now on, really. Now, have we any other questions that right, so the same, yes, the Ardens alert is the one that I was talking about. Right, if that's all of it for questions, I'm going to hand over to Catherine Pearson, who is from Target, and she's going to talk through more of the useful resources, and we really hope that you'll sign up to these. So over to Catherine.
Hi everybody. Just so that you know, you can go on to Target Ovarian Cancer's website and you'll find all sorts of things, but the things we really wanted to highlight for you is that we have a CNS-led helpline for your patients and for the people who are in their families. You can signpost your patients to this. It's open Mondays to Fridays, apart from bank holidays, 9 to 5, and you get straight through to a nurse to speak to. It has very good feedback, a well-evaluated service, so something that can help your patients, especially as they go through treatment and come out of treatment and around more complicated issues like dealing with clinical menopause and so on. So we do urge you to signpost your patients in that direction. We also have a drop-down menu called Health Professionals on our website, and you will find a lot of information there. So the Early Diagnosis Network sign-up form is there, the original report we did, access to some of the toolkits comes through there, but also access to our GP network and our quite considerable now catalogue of health professional ovarian cancer awareness resources, which we'll come on to, which Vicky has led on, and other people within our teams. And a quick call out, this is our early diagnosis email. It's important, there's 3 of us in the early diagnosis team, and if you use this email address, one of us will always get back to you. But particularly, if you have joined this webinar this morning as a result of getting a last-minute email from the charity, you will not have registered. And if you want to have the resources that come out of the webinar, including the recording of it, please email us on early diagnosis at Target Ovarian Cancer, and we'll make sure that you get all the resources that come out of it. This is an example of the type of resources that we produce. You can go onto our website and download them, or you can email us and we can send you paper copies of it. So this is a very recent piece of work that Vicky has been involved with, and other people, saying exactly what we're saying today, the importance of thinking of abdominal symptoms. And then something about the next steps for the Early Diagnosis Network program at the charity. We know that there are people in the network who are already using clinical alerts. Some of them are the Ardens ones, and some people are engaged in the ERICA trial being run by Exeter University. And what we'd like to do is we'd like to bring together everybody who's got practical experience of using these alerts together to share how impactful they think they are, so we can work towards sort of saying this is a gold standard of what an alert should look like. The one that Angela developed is available to everybody. You just have to email me and I can try and tie that up with you. I can send you the toolkit and Angela can help negotiate you to get the protocol for it. And as Angela said, it's useful, but also you can adapt it to meet your own specific circumstances and your own understanding of your population needs. So do take up that offer if that's useful to you, and we will be running a sort of public forum to discuss the impact of the different types of alerts. When we did the evaluation with the clinicians in Pennine, Lancashire, they recommended that the charity took forward 2 pieces of work. One was that we developed something around gold standard safety netting, and the physician associates were quite keen on that and quite keen to help us do it. And the other one was that all of these alerts rely upon good quality coding. So there was a call out that we should look at perhaps what best practice coding would look like. We're aware that that can be a minefield for everybody. What we'd like you to do is to let us know which of those 2 options you think we should prioritise, because we've got limited capacity this year and we would like to do one of them really well. And then finally, just to say, the next piece of work we're going to do is the work that Vicky's been leading on around thinking about abdominal symptoms and making the connection with ovarian cancer. So we're looking to have a broader conversation around that. Vicky presented very well at a general practice and public health conference about a month ago, very, very well evaluated and fed back on. We know it's a topical issue, so we'd like to take that forward. Let me just check. Vicky, are there any more questions in the chat that we need to go to?
Just a statement really from Sharon, who emphasises what we're trying to get across. Sadly, her mum was also treated by a GP and diagnosed with IBS for over a year. GP never did a CA125, presumably wasn't even thinking of ovarian cancer. And she was finally admitted to hospital where they had diagnosed her, but it was too late. She was in stage 4, and she's now been lost. And unfortunately, that is sadly the typical story that Target hear. And I think it's wonderful that GPs are wanting to do something about this, because we know that this is an area that we can be lacking in, and we can make a huge difference if we can try and do anything really to facilitate early diagnosis. Just another thing about the safety netting. I mean, thankfully these days, our IT support is getting so much better within practices. I mean, we've got obviously the pop-ups as we've discussed, but we've also got things like accurate texting. I've got one, for example, that I send out to people. Your CA125 is normal. If you're still getting symptoms, then please contact the surgery. Now that's set up on pathways through Accurate, and that goes off to them in a month's time. Again, you can do the same with urine frequency. So say, for example, they come into you and you think they've got a urine infection, but it comes back as all clear. You can send them a message to go off in a month's time saying, please contact us if you're still getting urinary symptoms. So we've got IT that we can use. The other advantage of ovarian cancer is that it's diagnosed mostly on symptoms. You won't really pick it up on an examination unless you've got barn door ascites or a huge tumour, which is very unlikely because ovarian cancer stays as quite a small tumour. It metastasises quite quickly. Again, it's done on questions. So if you are using telephone triage, for example, or any kind of IT triage, you've got much more likely chance these days to pick it up, because you're looking at the symptoms that they've come up with, and you can set up sort of red flag alerts on your triaging as well in the same way. So there's lots of things that we can do, as well as all of the things that we discussed, to try and help people like Sharon's mum from being misdiagnosed, really. So over to you, Catherine. I don't know whether we are done.
I suppose the most important thing is that we'd like you to stay in contact with us as a charity and to help us understand from your perspective whether things like these clinical IT alerts are really helping you to make a earlier diagnosis of ovarian cancer, and how we as a national charity can push that, you know, with our very good allies like Catherine at NHS England, to make that a very standard thing so that we can make a real change. And you know, the best way we think you can do that is probably to join us on the Early Diagnosis Network and be part of the conversation going forward. But we really want it to be a conversation so that we learn from you and your practical experience, and not just a one-way communication.
Yes, I mean, the thing with Target is they're very, very supportive, and they really, really want to help us diagnose, but equally they do want to support you as general practitioners and healthcare professionals to be able to do these things. So, you know, the resources are there. They've got loads of educational stuff on their website. I know I'm biased because I help them out and things, but they really are a good organisation. Plus the fact, if you do have somebody with ovarian cancer, please use their nurse support line, because that is absolutely invaluable. All the support tools, I get loads of certificates on what ovarian cancer is to hand out to patients when they come in for a smear test, for example. You can get the nurses to say, right, you've had your smear test, it doesn't cover you for ovarian cancer, here's a leaflet on it, and that tackles the 40% of women who unfortunately think a smear test magically controls that. So wonderful, wonderful resource, great charity, really enthusiastic, and they do a heck of a lot with the money that they get. So anyway, sorry, I will stop ranting and raving about them, because it is great. So just a huge thank you for you for joining us today, and I'm sure Angela and Catherine are very grateful to you all. So we will end it there, but don't forget, you can get this webinar online by contacting Target, and any other questions, do feel free to contact the office and we will do our best to answer them for you. So thank you very much.